Dear colleague, welcome to this presentation of DBS for movement disorders for referring physicians, Part 2, Who to refer and what to expect. My name is Patrick Blomstedt and I am Professor in Stereotactic Functional Neurosurgery at the University Hospital of Northern Sweden. No one knows exactly how many patients that potentially would benefit from DBS, but most of my colleagues would agree that we are reaching only a minority. If we look at Sweden, then in a population of 10 millions, we have during the last 10 years been performing about 120 DBS procedures a year. But there are large variations within the country, and the possibility to receive a procedure varies from 0.6 to 3.2 per 100,000 inhabitants, depending on where the patient is living. The difference is further much larger if we look at the different indications. And even larger differences in the penetrance of DBS is seen between different countries. And one of the explanations to these differences, at least within countries, is probably how familiar the referring physicians are with the procedure. The referring physician is thus of utmost importance for successful DBS therapy, both regarding the quantity and the quality. DBS is a small and highly specialized therapy used at a few hospitals. My own unit serves half of Sweden and receive patients from 10 smaller hospitals, and we are completely dependent on the referring physician's ability to identify suitable candidates. When the patient is referred to us for consideration of DBS, he or she will be evaluated by myself, our neurologist, DBS nurse and neuropsychologist. The DBS nurse will evaluate the patient according to various scales and in Parkinson's disease both on and off L-dopa medication. These evaluations are documented on video, so we can always go back after surgery to see what we have achieved with DBS. Importantly, the DBS nurse will also discuss the aims of the operation with the patient, and the patient will write these down. It is important that the patients define for themselves what they hope to achieve and what degree of improvement that would make them satisfied and what impact they expect this to have on their life in general. I believe that if we cannot meet the patient's expectations, then I will advise them not to have DBS. The neurologist will examine the patient, confirm the diagnosis, that the medical treatment has not been satisfying, and decide if further pharmacological treatments might be tested before DBS. The neuropsychologist will then evaluate the cognitive faculties. And finally, the neurosurgeon will make sure that there are no surgical contraindications, that the general health condition is acceptable, and that the patient has a reasonably healthy brain, as seen on MRI. Further, we will discuss the details of the procedure and make sure that the patient has reasonable expectations. Thus, please remember that you are not referring patients for DBS. You are referring patients for evaluation and consideration of DBS, with the final decision left to the DBS center. Hence, there are no risks with referring patients that might not be optimal candidates for DBS. It's important that you are not too picky when referring patients. Even though we have rather well-defined selection criteria for DBS, the perfect patient for DBS is rare, but there are many good candidates. When referring patients, it's better to be sensitive than specific, and it is better to let the DBS center discard unsuitable patients than to miss patients that could be helped by DBS. But with that said, you can of course not refer all patients with Parkinson's disease, essential tremor or dystonia. You need to apply some selection criteria. So let's look closer at these. It is often recommended to wait for 3 years before considering DBS in order to be reasonably sure regarding the diagnosis, and some centers prefer to wait 5 years for this reason. And this is an excellent rule especially in Parkinson's disease, but in a few cases with tremor dominant disease, the suffering of the patient will be so severe that earlier surgery is indicated. And this is sometimes true also in dystonia, where the patients should be considered for DBS once the symptoms are deemed severe enough. In essential tremor, the progress is usually slow and the duration of disease is seldom an issue. For us, it is very important that the patients have reasonable expectations, and a well-informed patient is a prerequisite for a successful therapy. For that reason, we will suggest all patients refer to us to watch 2 videos before coming to us for evaluation. The first video deals with the surgery and DBS as such, and the patient will then continue with the next video covering their specific condition, Parkinson's disease, dystonia or essential tremor. The idea with these presentations is that they will here get the same information as at a consultation, but in a more detailed and pedagogic manner. You will find these on YouTube, and you're welcome to suggest your own patients to have a look at them. We are in these videos discussing also the different variations in which the procedure are done around the world, so I believe them to be of a general value for the patients. We will later look at the indications for DBS in detail, but let me just here go through the major points for you as a referring physician. And let's start with Parkinson's disease. When the patient is first diagnosed with Parkinson's disease, he or she will present what after the introduction of L-DOPA is known as OFF symptoms, such as tremor, hypokinesia and rigidity, and the patient will then be started on dopaminergic medication. And as long as oral medication provides a good effect, other treatments should not be considered. This will usually be sufficient at least for several years during the so-called honeymoon period, before more advanced therapies will have to be considered in some patients. And it is of utmost importance to identify the patients in need of advanced therapies early on. And this is since our window of opportunity is in one sense narrow. Even though DBS will continue to be effective for the same symptoms both early and late on in the disease, the degree to which the patient can benefit from the symptom reduction will decline over time. A patient treated with DBS before the symptoms have resulted in loss of work and a reduced social network will, in our experience, often retain these for a significant time. But a patient who has lost this will seldom regain these losses, even if DBS is successful. Hence, it is of importance that the referring physician don't miss this window. However, the window will never open at all in most of the patients. Probably less than 10% of patients with Parkinson's disease are good candidates for DBS. We have discussed the contraindications for DBS, and many patients are too old or in too poor general health for you to refer, or at least for us to accept. Many have a satisfying symptom control with oral medication, and some patients with an unsatisfying effect of oral medication do not have symptoms suitable for DBS. A typical example is a patient with severe OFF symptoms with low L-DOPA responsivity, such as freezing and balance issues. So, which patients should you refer? Well, I think that you should be generous when deciding whether to refer a patient for evaluation of possible DBS. If you're only referring excellent candidates, then it is likely that you are missing a number of patients who would have done well with DBS. So, to decide on which patients to refer for DBS, let's first recapitulate what DBS is doing. DBS has almost the same effect as L-DOPA, but better on a few symptoms, mainly tremor and dystonic symptoms. The combination of DBS and medication is superior to either treatment alone. When DBS is added, the medication can be reduced. In contrast to medication, DBS is delivered continuously and can stabilize the effect over the day in patients with fluctuations. This is also the case during the night, and this is experienced as a big relief by many patients. We consider DBS when oral medication does not provide sufficient relief of symptoms for tremor or for fluctuating effect with on-off phenomenon. And also when the medication is causing unacceptable side effects such as dyskinesia or other side effects such as dopamine agonist-induced impulse control disorder. Thus, I suggest you to refer patients in whom any of the following symptom is clearly interfering with the patient's quality of life, including work and social relations. Patients in whom tremor or dystonic symptoms are causing a suffering despite medication. Patients suffering from dyskinesia. Patients with disturbing side effects from the medication, including impulse control disorder. And patients suffering from fluctuations. A helpful rule of thumb, especially regarding the fluctuations, is that the patient should be referred for consideration of advanced treatments, including DBS, when fulfilling at least one of the 5-to-1 criteria, suggesting advanced Parkinson's disease. That is, taking L-Dopa by mouth at least 5 times a day, having at least 2 hours of the day with off symptoms, or having at least 1 hour of troublesome dyskinesia. So, just to repeat some basics regarding fluctuations, in case anyone watching this is not a neurologist. When a recently affected patient takes the L-Dopa medication, this will be transported and stored in the brain and released gradually in a sufficient amount to ensure a good symptom reduction, and the patient is then in the so-called on-medication state. Later on, we will see the development of dopaminergic sensitization with increasing motor as well as behavioral response to dopaminergic treatment. This is partly caused by the pulsatile administration and by the non-physiological changes of the dopamine receptors caused by the dopamine agonists, but the most important mechanism is the progressive degeneration of dopaminergic neurons. And with this follows a decreasing ability to store dopamine and a more pulsatile release, and the store will last for a shorter and shorter length of time after the patient has taken the medication. And when the store is depleted, the Parkinsonian symptoms will of course return. The patient is then in the so-called off-medication state, as in this patient, where we see tremor, bradykinesia, and painful dystonic cramps. To counteract this, there will be a need for larger doses, administered more and more often. Another problem with sensitization and reduced storage capacity is that when the patient takes the medication, there is not enough room to store this, but instead an excess of L-Dopa will be released directly, which might cause involuntary movements, so-called dyskinesia, as seen in the same patient here. Hence, as the disease progresses, the patient will spend more and more of the day with a too low level of L-Dopa in the brain and with more symptoms, that is, in the off state. Further, when the patient takes the L-Dopa medication, this cannot be stored properly, which can result in involuntary movements. So over time we'll see a so-called on-off phenomenon, where the effect of the medication will show faster and faster oscillations between too little and too much, with less and less time spent at an optimal level with good symptom reduction. And in order to reduce these oscillations, the patient will start to take smaller doses more often, and sometimes as often as every second hour. Besides spending less time at a good level, The increasing number of times for medication will often be experienced by the patient as a significant problem in itself, reducing the quality of life and making it difficult to plan and execute normal activities over the day. There are two types of advanced treatments for Parkinson's disease, pumps and surgery. When fluctuations is the major problem, then pump treatments with duodopa or apomorphine can be considered. However, these systems are somewhat cumbersome and need constant attention. Further, even though there are no randomized studies, the effect of DBS seems to be better, at least concerning tremor, why, according to the Swedish guidelines, DBS should be excluded as an option before considering pump treatment. When discussing the effects of DBS, we need to realize that this is a generalization and that DBS is a very complex therapy. The effect of DBS in the individual patient depends on a number of factors, including how well placed the electrodes are, how skillful the programming is done, how well the stimulation is balanced with the patient's medication, the patient selection. Different patients have different symptoms, and DBS has varying effects on different symptoms. And also target selection. There are 3 different structures or targets in the brain used for DBS, all with different effects on the various symptoms. Further, in some patients we will only implant one side and in others both sides. Most patients will receive 2 electrodes, and unilateral surgery is only done in some patients with tremor-dominant symptoms who are deemed too old for a bilateral procedure or where only one side of the body is affected. Where the electrode is placed is dependent on the patient's symptoms and other factors such as age. The subthalamic nucleus, or STN, is the target of choice in Parkinson's disease and has unquestionably the best effect with a good reduction of tremor and improvement on bradykinesia, rigidity, dyskinesia and on-off phenomenon, and the L-dopa dose can be reduced. The VIM in the thalamus will have a good effect on tremor, but only on tremor. The VIM is mainly used unilaterally in some elderly patients with tremor-dominant disease not suitable for bilateral STN DBS. The pallidum, or GPI, is another option. It is perceived as harboring fewer risks than the STN in some elderly patients and is sometimes chosen due to relative contraindications, especially of a cognitive nature. The overall symptom reduction is lower than what can be expected from STN DBS, but the effect profile might make it a better choice in individual patients. It will have an excellent effect on dystonic symptoms and dyskinesia, a moderate effect on bradykinesia and rigidity, a more modest effect on tremor, and there will be no L-dopa reduction. Hence, this is not a suitable target when a medication reduction is desirable per se, for example in patients with impulse control disorder or hallucinations. The GPI is also appreciated by some neurologists since the postoperative optimization of medication and stimulation parameters is considerably faster and easier than in STN DBS. Here we see a patient with bilateral DBS for tremor. Tremor is often the symptom which is deemed as causing the most suffering by the patients, and DBS in tremor-dominant Parkinson's disease needs to be discussed in some detail. First of all, even though it is usually recommended to wait with DBS for 3 to 5 years after diagnosis in order to rule out other conditions, this is not always possible in cases of severe tremor causing intolerable suffering or interfering with work and such. Tremor is also the symptom which will demonstrate the largest symptom reduction with DBS. Typically, I will expect to remove around 90% of this symptom. Further, Parkinsonian tremor can be expected to respond well to DBS even if no major effect is seen from L-dopa on tremor in an individual patient. And finally, if it is deemed that the patient is too old, or for other reasons not suitable for bilateral surgery, then a unilateral procedure in the thalamic or subthalamic area might still be possible and beneficial, especially in patients with hemiparkinsonism. Here we see another patient operated with bilateral STN DBS. The patient is off medication in both videos, and actually he chose to be off medication for many years after DBS, which is unusual. Anyhow, here we see him with DBS off and on respectively. The patient has a slight tremor, which is absent on stimulation, but we see a more pronounced effect on his hypokinetic symptoms as seen in the different tests, and it is also visible in the facial mimic. It is always nice to look at videos, but it is more important to look at the scientific studies in order to know what we might expect from DBS. As I mentioned, the outcome is dependent on a number of factors, and there has been studies on STN DBS with modest improvements of the motor score around 30% 1 year after surgery, and other studies from centers of excellence of around 70%. And I believe that this meta-analysis of more than 2,000 patients with STN DBS provides a good understanding of what we can typically expect. In this analysis, they saw an improvement of UPDRS Part 3 motor score of 51%. The off time was reduced with 69%, dyskinesia reduced with 64%, and the medication with 50%. And the quality of life improved by 22%. The improvement compared to the preoperative state will gradually diminish over the years as the disease progresses, with levodopa refractory and stimulation-resistant motor and non-motor symptoms. However, the effect of STN DBS is rather stable over time in the sense that it will retain its effect on the specific symptoms for which it was performed. In this study by the Grenoble group, they evaluated patients with 15 to 24 years of STN DBS. 87 patients were dead or lost to follow-up, but in the remaining 51 patients, the off time was still reduced with 59% when compared to the preoperative baseline 15 to 24 years earlier. And dyskinesia was reduced by 75%, medication with 51%, and the quality of life improved by 14%. However, it is important to realize that the patients that are available for follow-up 24 years after surgery will constitute a selected material differing from the average patient. Remember also that it is not all about motor symptoms. Cognitive and limbic off and on symptoms will become more and more common as the disease progresses, and as a consequence of the dopaminergic medication, and especially due to dopaminergic agonists, and STN DBS can affect all of the three main loops, the motor, associative and behavioral, directly or indirectly through its impact on the dopaminergic medication. STN DBS will, as mentioned, reduce the off time significantly, and typically L-DOPA can be reduced with 50%, leading to a dopaminergic desensitization. Further, it will provide an opportunity to remove the dopamine agonists if the patient is suffering from an impulse control disorder. However, the reduction of L-DOPA should be done carefully while monitoring non-motor fluctuations as well as neuropsychiatric symptoms of the disease in order not to create a dopaminergic withdrawal syndrome with apathy. It can be a challenge to convey this information to the patients, but I try to explain most of this, but in a simple manner. I will summarize that I expect to reduce their symptoms with about 50% and that 9 out of 10 have a good outcome and are reasonably satisfied, while 1 in 10 have a poor outcome and would probably not undergo surgery again, knowing the outcome. I will inform the patients about possible complications and also warn them about the risk of success. Some patients have a truly excellent effect of DBS and might need to redefine who he or she really is, and the relation to family, friends, and the rest of society might change with new demands and expectations. How we inform the patient will of course have a major impact on whether or not the patient is satisfied with the therapy. And here we see how an experienced neurologist chooses to present the expected outcome. We have previously discussed the 5-2-1 rule, and the 50-20-10 rule might also be helpful. That is, that we can expect an improvement of 50% regarding motor and 20% for quality of life, while 10% of the patients will have a poor outcome. Let us now continue with essential tremor. We will deal with this in detail in the dedicated lecture, so I will here be very brief and just highlight a few points. Beta blockers are the first line of treatment. If this is not providing a satisfactory effect, then primidone or topiramate are often tried. However, it is estimated that 50% of patients will not respond well to pharmacological therapy, and other medications are only tried if DBS has been deemed unsuitable. Essential tremor is of course a very straightforward condition compared to Parkinson's disease, and I suggest you refer all patients who do not respond well to beta blockers. Primidone and topiramate might be tried or left for the DBS center to evaluate, who consider themselves to suffer so much that they are willing to undergo surgery, that have reasonable expectations and no absolute contraindications. But remember that most contraindications are relative, and in most patients who are deemed not suitable for DBS, this is not based on one single contraindication. Thus, be generous concerning this point and leave all except for the obvious cases to the DBS center to decide on. The experience of DBS for essential tremor seems to be rather uniform, and there is a consensus that DBS constitutes an effective and mostly well-tolerated treatment for essential tremor. If we look specifically at the treated hand, then I expect a tremor reduction and improvement in hand function of about 80%. And here we see a quite typical older patient with severe tremor before surgery and a good effect of DBS after surgery, albeit with a slight residual tremor as you see. We will in the coming lecture look at this in much more detail and also discuss the effect on tremor of voice and tremor of the head. Concerning what I will tell the patient, I will provide them all with the YouTube videos in here before the visit, and I will summarize that I expect to reduce their symptoms with about 80% in the treated hand, and that 9 out of 10 patients have a good outcome and are reasonably satisfied. I will further explain to them that the poor effect is often the result of the development of so-called tolerance, and I will stress the importance of turning the stimulation off during the night in order to reduce this risk. So, we then finally arrive at dystonia, and I will here just stress a few points since everything is well covered in the coming lecture. Let us first repeat what dystonia is. It is a heterogeneous group of conditions of different etiology and character. It is a movement disorder characterized by involuntary, sustained or repetitive muscle contractions, often of a painful nature, resulting in twisting and repetitive movements or abnormal fixed postures. Sometimes it appears in isolation and sometimes in combination with other symptoms such as tremor. Due to the large variations, it is difficult to discuss DBS in general, and I will here mainly limit the discussion to so-called isolated dystonia, that is, dystonia without spasticity, ataxia, etc. This new definition encompasses to a large extent what was previously known as primary dystonia. Mixed dystonia, which is quite similar to the old definition of secondary dystonia caused by cerebral paresis, trauma, anoxia, medicines, drugs or such, will not be discussed in any detail here. Dystonia is most often treated with medicine and botulinum neurotoxin injections, and as long as these provide a good effect, other treatments are not indicated. However, if sufficient symptom relief cannot be achieved, then DBS might be considered. And I suggest that you refer all patients with isolated dystonia who do not respond well to pharmacological treatment or botulinum toxin, and consider themselves to suffer so much that they are willing to undergo surgery and have reasonable expectations and no absolute contraindications. These suggestions are quite inclusive and may result in a number of patients who will later be declined by the DBS Center. But to give a more detailed and limiting recommendation would result in a number of patients being wrongly excluded from referral. Mixed dystonia is difficult. Basically, I believe that if it looks most like isolated dystonia, then it will respond rather well to DBS. However, in these patients, the dystonic symptoms, which might respond to DBS, are mixed with spasticity, motor overflow, ataxia, paresis, etc., which will not respond to DBS. And the best thing is probably to refer these patients in the same manner as those with isolated dystonia, even if most of them will be rejected by the DBS Center. Considering the heterogeneity, it is not surprising that there are considerable variations in the reported outcome. I myself expect an average improvement of about 70% with well-selected patients with isolated dystonia and well-placed electrodes. And to give you an idea of what can be achieved with DBS, I will show you a number of cases. Let us start with the case of blepharospasm. I apologize for the poor quality of this video. The patient is in this video attempting to open the eyes, but was unable to do so without using his fingers. To the right, we see the same patient after surgery. He has now no further problems from the eyes. Here we see a case with dystonia of the tongue. He was unable to speak since 2 years and had to feed himself with the syringe. And to the right, we see him 6 weeks after surgery.
Ja, det är i munnen. Och det jag inte kan prata på 2 år. Men nu går det bra som helst att prata efter operation.
Here we have a man with a painful torticollis, before and after surgery. The relief of pain is, by the way, often the first and often most appreciated effect of DBS. In the video to the right, the patient is demonstrating how he can now move the head without it twitching and shaking. Finally, I would like to show you a case of generalized dystonia affecting the whole body. The patient was before surgery moving constantly, had a poor gait and very poor fine motor skills. After surgery, he has no involuntary movements, his gait is much improved and his fine motor skills are excellent. In patients with isolated dystonia, I will summarize that I expect to reduce their symptoms with about 70% and that 9 out of 10 have a good outcome. In patients with mixed dystonia, the outcome is not as good and it is necessary to make a more individual estimation of what might be gained with DBS. And with that I end the present lecture. Those of you who are taking the course can now continue with the coming free lectures. And if you want further information, then you will find 200 more lectures and courses at the Stereotactic Academy. Thank you for your attention.